Hey guys, so today we are gonna learn about red blood cell disorders. First of all, let's see what is anemia. So anemia, there is a decrease in RBC count, hemoglobin or hematocrit values. Therefore, the ability of the blood to carry oxygen to the body tissues is reduced. So these are the symptoms and signs of anemia. The symptoms like lethargy, shortness of breath, palpitation, chest pain, headache, and dizziness and fainting. And the signs like pallor, tachycardia, and murmur. These are some values which we frequently use in case of red blood cells, like mean corpuscular volume MCV, and the normal value of this is 82 to 96 femtoliter. So this mean corpuscular volume, it is the average volume of RBC, and it is 82 to 96 femtoliter. So when it is below 80 femtoliter, we call it as microcytic anemia. And when it is more than 100 femtoliter, we call it as macrocytic anemia. Now MCH, it is the mean corpuscular hemoglobin, and that is the amount of hemoglobin per RBC. So the normal value is 27 to 33 picogram. And MCHC, it is the mean corpuscular hemoglobin concentration, and it is the ratio of MCH to MCV. That is, it is the ratio of mean corpuscular hemoglobin to mean corpuscular volume. So it is the average concentration of hemoglobin in a given volume of packed RBC, and the normal value is 33 to 37 gram per deciliter. So in this picture you can see normal RBC. In the normal RBC, it has a central pallor of 1/3 of its diameter. There is a central pallor. Now if the color is decreased, that means when the pallor is more than this 1/3 of this diameter, we call it as hypochromic. And what if the color is increased? There is no condition like hyperchromic, but we can say it is normochromic. That means when the color is increased, the pallor will be lost. So in that condition, we can call it as normochromic. Now here you can see the macrocytic and microcytic RBCs. So when we say about anemia, the causes of anemia, it can be due to blood loss, it can be due to defective production of RBC, or it can be due to increase in the destruction of RBC. So in the case of any blood loss, what actually happens is there is a decrease in hematocrit. So when this hematocrit is decreasing, there will be release of erythropoietin. To compensate this decrease in RBC, there will be release of erythropoietin so that can increase the activity of bone marrow. Thereby all the cells will be increasing. That means leukocytosis, reticulocytosis, and thrombocytosis. Here the earliest change that occur in the peripheral blood after acute blood loss is leukocytosis. So that is the earliest change that can happen in the peripheral blood after acute blood loss. Now another condition when you can get anemia is due to the impaired production of RBC. So here that can be due to if there is vitamin B12 deficiency or folic acid deficiency, there will be defective DNA synthesis. thereby causing megaloblastic anemia. And another condition is that when there is iron deficiency, there will be impaired synthesis of heme. In that condition also you can get this iron deficiency anemia. So vitamin B12 deficiency, folic acid deficiency and iron deficiency anemia, that comes under this category of impaired RBC production leading to anemia. Now another cause is when there is increased distraction of RBC. So we will be discussing about hemolytic anemia later on the session. So first of all, when we say about megaloblastic anemia, so we have already studied about macrocytic anemia. We must know what is the difference between this macrocytic anemia and megaloblastic anemia. In case of a macrocytic anemia, there will be increase in the size of RBC, but here in megaloblastic anemia, here you can get increase in the size of RBC. At the same time, you can also get nucleocytoplasmic asynchrony. So that is the difference between macrocytic anemia and megaloblastic anemia. So here the problem is impaired DNA synthesis. So usually you get this megaloblastic anemia due to the deficiency of folic acid or vitamin B12. Both this folic acid and vitamin B12 is required for the synthesis of DNA. So when these are deficient, when this folic acid and vitamin B12 is deficient, so this nuclear maturation does not take place. The nuclear maturation will lag behind this cytoplasmic maturation, and what we get is abnormally large nucleated erythroid precursors. So that we call as megaloblast. So these megaloblasts, they can undergo intramedullary distraction, and that is called ineffective erythropoiesis. Due to this ineffective erythropoiesis, there will be pancytopenia. So the number of the cells will be decreasing. As a result, there will be compensatory increase in the erythropoietin activity. So the total number of cells will be more than the normal. That means the bone marrow will be producing more and more precursor cells. So there will be a hypercellular bone marrow. The total number of cells will be more than the normal, but majority of them will be precursor cells. But still, due to ineffective erythropoiesis, the reticulocyte count can decrease. So due to this premature distraction of RBC, there is actually hemolytic anemia. And at the same time, there can occur jaundice, increase in the serum bilirubin level. Also, there can be increase in the lactate dehydrogenase enzyme. So in this megaloblastic anemia, what we usually observe in the peripheral smear is hypersegmented neutrophils, Howell-Jolly bodies and oval macrocytes. And one important thing to note is that MCHC is not elevated here. That means MCHC is normal. The mean corpuscular hemoglobin concentration is normal here. That is because the hemoglobin is increasing proportionately to the increase in volume of RBC. Therefore, MCHC is normal. So these are the megaloblasts which you can see in the peripheral blood. So this is hypersegmented neutrophils. Usually in a neutrophil you get 3 or 4 nuclear lobes, but in case of a hypersegmented neutrophils, it has almost maybe more than 5 nuclear lobes, or maybe at least 5 nuclear lobes. And the second picture which you can see is Howell-Jolly bodies, and you can see there is a basophilic nuclear remnants. of the DNA in circulating RBC. So that is called Howell-Jolly bodies. And in this picture, you can see again the hypersegmented neutrophils, and you can see some teardrop cells and also macroovelocytes. So the earliest manifestation of megaloblastic anemia is the presence of macroovelocytes. So we have found that megaloblastic anemia is caused due to the deficiency of vitamin B12 or folic acid. So now let us see what are the functions of vitamin B12. Vitamin B12 is required for the conversion of homocysteine to methionine and methylmalonyl coenzyme A to succinyl coenzyme A. So here what happens if there is no vitamin B12? Both these conversions will be disrupted. As a result, in the first case, the homocysteine levels in the blood will be increasing, and also it can increase the level of methylmalonyl coenzyme A in the blood, and also this methylmalonyl coenzyme A can be excreted through the urine. So there will be decrease in the formation of methionine, and there will be decrease in the formation of succinyl coenzyme A. So here the succinyl coenzyme A is actually required for the formation of myelin. So there will be some neurological manifestations in vitamin B12 deficiency. So these are the clinical features that you can get in the vitamin B12 deficiency in megaloblastic anemia. So here you can see, first of all, we have already said about the peripheral blood, that is hypersegmented neutrophils, the megaloblast, macroovelocytes, Howell-Jolly bodies, and we have seen that there is decrease in the formation of succinyl coenzyme A, by which there is decrease in the formation of myelin, and there will be neurological manifestations. So that condition is called as subacute combined degeneration. So in this is actually a progressively occurring. It's not happening very suddenly. It's a progressively happening condition, that is subacute combined degeneration, and it is involving both the ascending tracts and descending tracts of the spinal cord. There can be also involvement of the GIT. So we know that vitamin B12 is affecting the rapidly dividing cells. So that is why in vitamin B12 deficiency there can be mucosal atrophy. So usually our tongue is rough due to the mucosal papillae, but here since there is vitamin B12 deficiency, it becomes smooth due to atrophy, and that which we actually see in this vitamin B12 deficiency, that is in megaloblastic anemia, it is beefy tongue which is very smooth. Now it can also cause chronic atrophic gastritis, in which there is atrophy of the glands. Sometimes it can even cause intestinal metaplasia. So now we have seen that megaloblastic anemia is caused by the deficiency of vitamin B12 and folic acid. But what is the difference in the clinical features elicited by both? In case of a folic acid deficiency, there is no neurological manifestations. At the same time, in case of a vitamin B12 deficiency, you can get neurological manifestations, just like what we have seen, subacute combined degeneration. In both cases, there will be megaloblastic anemia, and in both cases, you can get the symptoms of anemia and jaundice, etc. So on treatment, while you treat this condition, either it is a folic acid deficiency or it's a vitamin B12 deficiency, we give both, that is folic acid plus vitamin B12 tablets, and not just any one alone, because though the symptoms of anemia can improve, neurological manifestations can worsen. That is why on treatment of any of these conditions, we give both these tablets together, that is folic acid plus vitamin B12 together. So now let us see about pernicious anemia. So we know that for the absorption of this vitamin B12, it requires Cassell's intrinsic factor, which is needed for the absorption of vitamin B12, and this intrinsic factor is produced by the parietal cells of stomach. So this intrinsic factor will bind with vitamin B12 and their absorption take place in ileum. This is what exactly happens. But here in pernicious anemia, it is an autoimmune disease. As a result, there will be formation of the autoantibodies, which is not allowing this intrinsic factor to bind with vitamin B12, or sometimes there will be deficiency of the intrinsic factor. So as a result, this vitamin B12 cannot be absorbed into the GIT. So since vitamin B12 is not absorbed, there will be features of megaloblastic anemia. So in this condition, in pernicious anemia, what is actually the difference with megaloblastic anemia is that here in pernicious anemia, since it is an autoimmune disease, you can demonstrate the autoantibodies. But the clinical features can be similar to the megaloblastic anemia, like the clinical signs and symptoms of anemia, jaundice, and even the neurological manifestations can occur here. So here in pernicious anemia, you can get the autoantibodies that you can see here as type 1, type 2 and type 3 antibodies. So first of all, the absorption of vitamin B12, the intrinsic factor and the vitamin B12 has to form a complex. First of all, this vitamin B12 and intrinsic factor has to bind to each other. So this binding is inhibited by type 1 autoantibody. And once they have binded each other and formed a complex, now they are gonna bind to the receptors which is present in the ileum, by which they get absorbed into the ileum. So this binding to the ileal receptors is actually inhibited by the type 2 autoantibodies, and type 3 autoantibodies is actually produced against the parietal cell, so that there is decrease in the secretion of intrinsic factor. So all these three autoantibodies, you can get any one of them in pernicious anemia, and the most specific one which you get is type 1 autoantibody. So now here let us see what are the different causes of vitamin B12 deficiency. So it can be due to the decreased intake, or it can be due to the decreased absorption, or due to the increased requirement. So when we say about decreased intake, especially for the people who have vegetarian food, in that case they can have decreased intake of vitamin B12, and vitamin B12 deficiency may be due to the decreased absorption, that is when you get some intrinsic factor deficiency, or maybe in some intestinal disease, some kind of malabsorption or some kind of infections that can impair the absorption of vitamin B12. Now in some cases you can have increased requirements of vitamin B12, just like in case of the children, in case of female when during the pregnancy or lactation. So during that time you can get this vitamin B12 deficiency due to increased requirement. So here I would like to introduce a test, that is Schilling test, and this is a test which cannot diagnose vitamin B12 deficiency, but once if it is already diagnosed, you can identify the cause of this. That is, you can differentiate the megaloblastic anemia due to intrinsic factor deficiency from other causes of vitamin B12 deficiency. So by this Schilling test, you can find out whether the problem is due to intrinsic factor deficiency or whether there is some other causes. So you can actually identify the cause, you can differentiate the cause but at the same time, here you cannot diagnose vitamin B12 deficiency. So now we are going to discuss about iron deficiency anemia. So first of all, we must know about the absorption of iron. So iron absorption is actually taking place in the duodenum, and absorption of iron is in the ferrous form. So iron can actually exist in ferrous form and ferric form, and the absorption of iron takes place in the ferrous form via a transporter called as divalent metal transporter. So by this divalent metal transporter, you can see in this picture, the iron absorption takes place in the duodenum. Now when it enters to the enterocytes, so here actually it is absorbed in Fe2 plus form, that is ferrous form. Now once it has already entered into this enterocyte, it has to get converted into ferric form, that is Fe3 plus form, and this is done by a protein called as hefoestin or ceruloplasmin. So by this protein, this ferrous form is converted into ferric form. So now it is then leaving the basal surface of this enterocyte via another transporter, and that is called as ferroportin. So by this ferroportin transporter, this iron leaves the enterocyte and now it reaches to the bloodstream. So in this picture also you can see those transporters. Here this iron has already reached into the bloodstream via the ferroportin transporter. Now when it reaches into the bloodstream, it is transported by another protein called as transferrin. So this transferrin helps in the transportation of iron, and then it can bind to the transferrin receptors which is present in different cells. Especially some cells have many of these receptors, like liver cells in case of bone marrow, etc. So here you can get this transferrin receptors to which this transferrin will bind, and this iron is entering into the cells. They are incorporated with apoferritin to form ferritin. So ferritin is the storage form of iron. Here you can see in this picture, iron is stored in the form of ferritin, and if there is an excess iron, it is stored in the form of hemosiderin. So unlike ferritin, hemosiderin, it is a more stable form of iron, and it is because of this hemosiderin you're gonna get positive Prussian blue stain. That means it turns blue-black when exposed to potassium ferrocyanide. Now in cases of iron deficiency anemia, when there is decreased storage iron, you get a negative Prussian blue stain. So small amount of ferritin is also present in plasma, and that is serum ferritin. So the serum ferritin is an indicator of body iron stores. So when you want to know about whether there is a decrease in the storage iron, you can actually check for serum ferritin, because serum ferritin is an indicator of body iron stores. Now let us see what are the stages of iron deficiency anemia. It can be given in 3 stages. In the first stage, the first thing which is gonna get affected in iron deficiency anemia, it is that there is a decrease in the storage form of iron. That means there is decrease in the serum ferritin, because we know that serum ferritin is actually an indicator of body iron stores. So at this time, when you check for Prussian blue staining, you get it is negative. Now the second stage, it is iron deficient erythropoiesis. So here there is reduced iron stores, there is reduced serum ferritin, there is decrease in the percentage saturation of transferrin. At the same time, there is an increase in the total iron binding capacity. But what is important to note in these two stages, in the first stage and in the second stage, there is not going to be affected the morphology of the RBC. Morphology of the RBC is not going to get affected. But in case of the third stage of iron deficiency anemia, you get microcytic hypochromic anemia. That means the morphology of the RBC is getting affected. So they can come in different size, they can come in different shape, there can be anisocytosis, there can be poikilocytosis. And when you look for the red cell indices, there is a reduced MCH, MCV and MCHC. So here in this peripheral smear, you can actually see different sizes and different shapes of RBC, and most commonly it is microcytic hypochromic anemia is seen in iron deficiency anemia. You can also see some other cells like pencil shaped cells, or even you can see some target shaped RBC in this picture. So these are the clinical features of iron deficiency anemia, and the first thing which you can see, that is a spoon nails, we call it as koilonychia. And the second one, there is an ulceration at the angle of mouth, that is angular stomatitis. So it can also cause chronic atrophic gastritis, it can affect the GIT, and there are some non-specific findings just like fatigue, palpitation, breathlessness, etc. So now let us see what is sideroblastic anemia. Sideroblastic anemia, it's a group of blood disorders in which the body has got enough iron but it is not able to make hemoglobin. That means the iron is accumulated in the mitochondria of the RBC, giving a ringed appearance to the nucleus. So that is, you can see in this picture, the ringed sideroblast. So now let us learn about anemia of chronic disease. Here you're getting some chronic inflammation, and due to this chronic inflammation there is release of the cytokines. So there will be increase in the protein called as hepcidin, and this hepcidin is actually inhibiting the release of iron from GIT, also from bone marrow. So normally this iron comes into the bloodstream either by the absorption from GIT or either it is released from the bone marrow. But here what exactly happening it is, this hepcidin is the protein which is actually inhibiting this iron transporter, that is ferroportin. As a result, you have iron in the storage form in your body, but at the same time the serum iron will be less. So what you can see here is the serum ferritin level is high. That means iron is there in the storage form, but at the same time the serum iron is less, and also the percentage transfer in saturation and the total iron binding capacity is low. Here in this anemia of chronic disease, usually it is not gonna affect the morphology of the RBC. That means usually you get normocytic normochromic anemia, but at the same time only in some cases you can get microcytic hypochromic anemia. So usually you can say in anemia of chronic disease you get normocytic normochromic anemia. So now let us see what is aplastic anemia. So as you can see in this picture, most of this hematopoietic stem cells in the bone marrow, it is replaced by the fat cells. So the bone marrow is markedly hypocellular, and that is a characteristic feature of aplastic anemia. So here you can see that the pathogenesis, either it can be the direct damage to the hematopoietic stem cells, or either it can be some immune mediated destruction. That is, when some antigens are exposed, the T cells can be activated against that. So that is immune mediated destruction, and it can be also some inherited defect in the stem cells. So Fanconi's anemia, it is the inherited form of aplastic anemia. So you can remember this etiology of aplastic anemia by 5I: idiopathic, ingestion of drugs and chemicals, irradiation, infections, and the inherited cause of aplastic anemia is Fanconi's anemia. To see about the clinical features of aplastic anemia, here, since the hematopoietic stem cells are getting affected, there will be pancytopenia. That means all the cells are getting affected. So there will be decrease in the RBC, decrease in WBC, and decrease in platelets. So the non-specific symptoms like fatigue, dyspnea, pallor, you can observe them. At the same time, since there is a decrease in the total leukocyte count, especially there is decrease in the neutrophils, that is neutropenia, so you can get recurrent infections. And also there is thrombocytopenia, there is decrease in the number of platelets, so bleeding manifestations can also be observed. And when you look at the lab findings, there is decreased hemoglobin, decreased PCV, and there is decreased reticulocyte count. There is no splenomegaly observed in aplastic anemia. Since the stem cells are getting affected, they are getting destroyed. So here there is no splenomegaly is observed in aplastic anemia. So now let us see about hemolytic anemia. In hemolytic anemia, there is hemolysis. That means there is distraction of the RBC. There is increased distraction of the RBC, which is more than the compensatory response of the bone marrow. That's why you can get this hemolytic anemia. So the causes of hemolytic anemia based on the location of hemolysis, if it is within the systemic circulation, it is intravascular, or it can be extravascular when it's outside the systemic circulation. And based on the source of defect which is causing hemolysis, whether the defect is within the red blood cells, that means it's intracorpuscular defect, or whether it's outside this red blood cells, then that is extracorpuscular defect. And the mode of onset, it can be inherited or it can be acquired. So when you differentiate between this intravascular hemolysis and extravascular hemolysis, first of all, we know that if it is intravascular hemolysis, it's occur within the circulation. At the same time, extravascular hemolysis means it's outside the circulation, especially the reticuloendothelial system. That means the spleen, the bone marrow. So in this condition, you can get splenomegaly in extravascular hemolysis, because here the RBC distraction occurs in the organs like spleen and bone marrow. So that's why you can get splenomegaly in extravascular hemolysis. Now, what are the lab findings that you can get in extravascular and intravascular hemolysis? See, in intravascular hemolysis, there is distraction of the RBC, so there within the circulation. So there will be release of the free hemoglobin, and this hemoglobin is actually captured by a serum protein called as haptoglobulin. So in this condition, the serum haptoglobulin level will be decreasing, because it has to form always a complex with this released hemoglobin, so that the level of the serum haptoglobulin is decreasing. Later, sometimes when this hemoglobin more amount is released into the bloodstream, it can be even filtered by the kidney and it can cause hemoglobinuria. So there will be alteration in the color of urine. And even sometimes this hemoglobin can be oxidized into methemoglobin. So methemoglobinemia can also occur. And unconjugated bilirubin can be formed due to the metabolism of this heme. So that is what you can see here. Hemoglobinemia can be seen in intravascular hemolysis, whereas it is absent in extravascular hemolysis. And therefore, the serum haptoglobulin level will be decreased in intravascular hemolysis, and due to the metabolism of heme, the serum bilirubin level can be increased. So it can be moderately increased in extravascular hemolysis and mildly increased in intravascular hemolysis. So hemoglobinuria can happen in intravascular hemolysis. The hemoglobin which is released into the circulation that can be filtered by the kidney and excreted via urine. So since there is hemoglobinuria in intravascular hemolysis, sometimes this hemoglobin can even enter the cells of PCT, which later these cells of PCT, when they die, they are thrown into the lumen and they are having hemoglobin in them. So that is renal hemosiderosis. So this hemosideruria is actually observed in intravascular hemolysis. Some examples of intravascular hemolysis like G6PD deficiency, paroxysmal nocturnal hemoglobinuria, whereas extravascular hemolysis, examples are thalassemia and sickle cell anemia. So in bone marrow, since there is a distraction of RBC happening in this hemolytic anemia, there will be compensatory increase in the production of RBC also. That's why in the bone marrow you are getting compensatory erythroid hypoplasia. As a result, in the peripheral blood you get reticulocytosis. But the size of the RBC, they can vary, the size and shape can vary, so there can be anisocytosis and poikilocytosis. So since there is distraction of the RBC, so there can be increase in the serum iron, and also this iron which is released into the blood can be even stored by the cells. So here there is increase in the serum iron and there is increase in the stored form of iron. So in hemolytic anemia, it can be due to intracorpuscular defects or it can be due to extracorpuscular defects. So when you say about the intracorpuscular defects, there is defect within the RBC and it can be hereditary or it can be acquired. So the acquired cause of this intracorpuscular defect in hemolytic anemia, it is paroxysmal nocturnal hemoglobinuria, whereas most of them are hereditary, like when you have a problem with RBC membrane, just like in hereditary spherocytosis or hereditary elliptocytosis. When you get a problem in case of enzyme, when there is an enzyme deficiency, just like G6PD enzyme deficiency, or sometimes there can be defect in the hemoglobin. A qualitative defect in the hemoglobin is observed in sickle cell anemia, whereas a quantitative defect of hemoglobin is observed in thalassemia. So all these, the problem is within the RBC membrane, so that means it is within the RBC, so that means it is an intracorpuscular defect. When we say about the extracorpuscular defects, usually it is immune hemolytic anemia. It can be autoimmune hemolytic anemia, alloimmune hemolytic anemia, microangiopathic hemolytic anemia, or sequestration. So first of all, hereditary spherocytosis. So hereditary spherocytosis, it is a hereditary cause. It is an intracorpuscular defect. It is an autosomal dominant disorder. So here the problem is there is a defect in the red cell membrane due to the deficiency of a cytoskeletal protein. So in hereditary spherocytosis, the most common protein which is involved, it is ankyrin. It can be also band3 or it can be spectrin. So any defect in these proteins, when there is a deficiency of any of this cytoskeletal proteins, what happens is that the membrane of the RBC becomes unstable. So that is why there will be a loss of the membrane. A small part of the membrane will be lost, and later they attain a spherical shape. So that is hereditary spherocytosis. So since it is a hemolytic anemia, and here the destruction of these RBC takes place in reticuloendothelial system like spleen. So that is why you can see here splenomegaly. And you can observe anemia, jaundice. Since it is a hemolytic anemia, there is a distraction of RBC. So you can get anemia, you can get jaundice. Here the normal MCH is seen, and there is a decrease in MCV and there is an increase in MCHC. In this picture, you can observe the proteins pectin, ankyrin, band 3, etc. So these proteins deficiency, mostly due to ankyrin, you're gonna get hereditary spherocytosis. When you have a deficiency of the protein pectin, usually you're gonna get hereditary elliptocytosis. So these proteins are needed for the stability of this RBC membrane, and when these proteins are deficient, the RBC membrane is going to be unstable. So in this picture you can see spherocytes. So in the hereditary spherocytosis, definitely you can see spherocytes in the peripheral smear, and the speciality is that they are small and darkly stained. You cannot see central pallor, and they have almost a spherical shape. So central pallor is absent in these spherocytes. So since these RBCs are spherical in shape, they can easily burst. So when you do an osmotic fragility test, you can see that there is an increased osmotic fragility, and when you record it as a graph, you can see the curve is shifting to the right. So there is an increased osmotic fragility in hereditary spherocytosis. So this is an elliptocyte, and the most important protein which is involved in hereditary elliptocytosis is pectin. So now let's see what is G6PD deficiency. So here an enzyme defect is present, that is glucose 6-phosphate dehydrogenase enzyme, and it is an intracorpuscular defect. It is an inherited one. So it is X-linked recessive disorder. So when this enzyme defect occurs, RBCs are susceptible to oxidative stress. That means when these RBCs are exposed to oxidative stress, just like when there is an infection or due to some drugs, or when the person is having fava beans, in all these cases there is some kind of oxidative stress. So the hydrogen peroxide will be accumulating, and there will be free radical damage to these RBC. So these oxidative stress, due to the presence of this, the RBCs are gonna get damaged because there is a defect in this enzyme. In normal cases, due to the presence of these enzymes, they are able to tackle all these kind of oxidative stress, but here, since there is a defect in this enzyme, they are susceptible to this oxidative stress, and there will be destruction of RBC. So here the hemoglobin is oxidized to form methemoglobin, and they form Heinz bodies, which we can observe in RBC. So this Heinz bodies, when they are removed from RBC, especially when the macrophages remove this Heinz bodies from these RBCs, bite cells are formed. So we are going to look at these pictures. Here you can see Heinz bodies. It is formed by the oxidation of hemoglobin to form methemoglobin, and they are forming this Heinz bodies. And when these Heinz bodies are actually removed by the splenic macrophages, or even within the circulation. When these Heinz bodies are removed by the macrophages, they form bite cells. So here you can see it's just like somebody have bitten them, these RBCs. So they are called as bite cells. So these RBCs are actually damaged in the systemic circulation, that means intravascular hemolysis. But sometimes they could actually escape this in the circulation, and somehow they can reach the spleen. So even if they reach the spleen, they will be phagocytosed by the splenic macrophage, producing extravascular hemolysis. So here you can get both intravascular and extravascular hemolysis, but most importantly in G6PD deficiency you're gonna get intravascular hemolysis. So this condition is a self-limiting hemolysis. That means the old cells are getting affected. Mostly the old cells are hemolyzed. So there can be, when the old cells are hemolyzed, there can be a compensative response, from the body, that there will be increase in the production of new cells, new RBCs can be produced. So as each new wave of red cell is appearing, anemia becomes less and less severe. So that means this anemia is actually short-lived. But sometimes in some patients they need some supportive therapy. So here you can see that it's a self-limiting hemolysis. That means the old cells are getting affected, so that when new and new RBCs are formed, the problem is almost solved. That is, it's called self-limiting. And it's offering a protective response against Plasmodium falciparum malaria. That means here in case of G6PD deficiency, here there is a rapid clearance of RBC. So as a result, the parasites, they cannot stay in the body for a long time. They don't have much time for the proliferation in the body, because there is rapid clearance of the RBC. So just like that, the rapid clearance of these parasites are also easily removed. So that's why it's offering a protective response from Plasmodium falciparum malaria. So now let us see what is thalassemia. So in thalassemia there is abnormality in the globin production. So you know that in the hemoglobin you have a heme portion, you have a globin portion. So when you have abnormality in the globin production, that is thalassemia, here you can, in the globin itself you have 2 alpha chains and 2 beta chains. It's alpha 2, beta 2. So when there is a decrease, or when there is absence of synthesis in this alpha chain or beta globin chain, you get 2 types of thalassemia. So it can be beta thalassemia or it can be alpha thalassemia. So in case of a beta thalassemia, there is an impaired synthesis of beta chain of globin. At the same time, in alpha thalassemia, there is an impaired synthesis of alpha globin chain. So first of all, we will be discussing about the beta thalassemia. Beta thalassemia, it can be beta thalassemia major, it can be intermediate, and it can be minor. So in case of the beta thalassemia major, it is a severe anemia and it is even blood transfusion dependent. So in this case, you need blood transfusion to manage the patient. And in beta thalassemia intermedia, it is moderately severe and it is not transfusion dependent. When it is beta thalassemia minor, it's minor. So it is a mild anemia and it's usually asymptomatic. So in beta thalassemia, there is impaired production of beta globin chain. And the gene which is producing this beta globin chain, it is having 2 alleles. So in case of thalassemia major, here both these alleles are defective and there is a severe decrease in the production of beta globin chain. So the condition is so severe that the patient needs blood transfusion for management. In the case of this beta thalassemia intermedia, though both the alleles are getting affected, there is a partial synthesis of this beta globin chain so that the condition is moderately severe and it is not blood transfusion dependent. In case of beta thalassemia minor, it is also called as thalassemia trait, where only one allele is getting affected. So there is mild anemia and it is almost asymptomatic. So when you look into the peripheral blood, you get microcytic hypochromic anemia, anisocytosis, poikilocytosis and target cells can also be observed in this beta thalassemia. So here we know that there is an impaired synthesis in the production of beta globin chain. That means there is a relative excess of alpha chain. So this alpha chain can get precipitate and that's why there can be intramedullary destruction of RBC. That means there will be ineffective erythropoiesis. Even if they are able to escape into the circulation, they will be trapped inside the spleen, and when they reach the spleen, what happens is that there will be phagocytosis by the splenic macrophage. That means extravascular hemolysis can happen. So as a result of all these, there is destruction of RBC. So definitely there will be a compensatory response. There will be increase in the bone marrow activity. So that's erythroid hypoplasia you can see in here. Also there will be extramedullary hematopoiesis. So as a result, you can get some changes in the bone. Like in the skull X-ray, you get a particular appearance, that is hair on end appearance or crew cut appearance. And there is something called as thalassemic facies. It's also called as chipmunk facies. We will be looking at the pictures right now. So here there will be iron overload. Since there is destruction of RBC, the iron will be released into the circulation. So iron in the circulation can get increased due to hemolysis, and also there will be absorption of iron from the GIT. So that can also increase iron. At the same time, since some patients need blood transfusions, in that way also iron can increase. So iron overload can happen in such thalassemic patients. Now when we take the age when we can see manifest this condition is that usually in infants in their early age we are not gonna observe this, because since they have fetal hemoglobin in their body, we cannot understand this. Only 6 to 9 months after birth, these infants will develop moderate to severe anemia. So when you look at this picture, the first one which you are seeing, it is the chipmunk facies or thalassemic facies, and the second one in the skull X-ray you're gonna get a crew cut appearance, or we say hair on end appearance. In this picture you can see target cells. So target cell, it is a morphologically abnormal RBC. Here you can see it's just like a target. I mean, the hemoglobin is redistributed in such a way that only the peripheral region and the central region of RBC is appearing with hemoglobin. In between you have a pale area, so it just resembles like a target. So these target cells you can see in thalassemia major, sickle cell anemia, etc. Now to confirm the diagnosis, you can use HPLC, that is high performance liquid chromatography. So here in case of a thalassemia major patient, you can see that fetal hemoglobin will be increased in such patients because there is an impaired production of the beta globin chain, you have an excess alpha chain, an alpha globin chain. So they can actually combine with the delta chain so that there will be increase in the formation of fetal hemoglobin. So this is actually observed in high performance liquid chromatography, and this is used for the confirming the diagnosis of thalassemia major. This is another test which we perform, Nestrov test. Nestrov is actually naked eye single tube red cell osmotic fragility test. So this test will be positive. In this test, we are actually taking 0.2 ml patient's blood is added to 5 ml of 0.35% saline in a test tube. So behind this test tubes, we actually have to place a white paper with a dark line, which you can see in this picture. So in thalassemia, what happens is that we know it is microcytic hypochromic RBCs in thalassemia. So these RBCs, in case of a thalassemia minor patient, this microcytic hypochromic RBCs are resistant to the lysis than when we compare to a normocytic normochromic RBCs. So you can see lysis will be there for a normal patient's blood. At the same time, when you take a thalassemia patient's blood, there is no lysis because it is microcytic hypochromic RBCs are present there. So that is why the black line will not be clearly seen in thalassemia patient sample. At the same time, in case of the normal patient's blood, since there is lysis, the black line which we have drawn behind on the white paper, we can observe it. So this test is positive in alpha thalassemia, sickle cell anemia, and also in iron deficiency anemia. So this is Nestrov test, that is naked eye single tube red cell osmotic fragility test. It is some way just like an osmotic fragility test which we can observe even by the naked eye. So here the first sample which you can see, the black line behind is not observed, and that's a thalassemia patient's blood. At the same time, the second one, you can see the black line behind it. So that means it's a normal patient's blood. Now, in case of an alpha thalassemia, there is impaired synthesis of alpha globin chain. So it can be in 4 ways. First of all, it can be a silent carrier state in which one alpha globin chain is deleted, and that condition is asymptomatic. So first of all, we have to know that there are actually 4 alleles for this gene which is producing alpha globin chain, and only one is getting affected, that is a silent carrier state, and it is asymptomatic. At the same time, when half of them, that is 2 alleles, are getting affected, that becomes a trait, alpha thalassemia trait, and it is usually asymptomatic. So you get normal hemoglobin, or sometimes there can be minimal anemia. Now when 3 alleles are getting affected, that is, we call it as hemoglobin H disease, and here it is moderate microcytic anemia. Now when 4, that means all these alleles are getting affected, in that condition it is Bart's hemoglobin, and this is a very severe condition since all the 4 alleles are getting affected, and here it is almost fatal. So this hydrops fetalis can occur in such patients, and mostly they will be having intrauterine death. It is a very severe form such that it is fatal. So now let us see about sickle cell anemia. So in sickle cell anemia, Till then we have been discussing about thalassemia where there is a quantitative defect in the hemoglobin. At the same time, in sickle cell anemia there is a qualitative defect in the hemoglobin where in the beta globin chain in the 6th position, instead of glutamic acid, it is replaced by valine. So here you can get in two ways. It can be sickle cell anemia or it can be sickle cell trait. So sickle cell anemia, that sickle cell disease, when it is a homozygous condition, that means both the beta globin chains are defective, that's they are abnormal. So we know that it's alpha to beta 2. So when both this beta globin chains are getting affected, that can be sickle cell anemia. At the same time, when it is a heterozygous state, when only one of the two beta globin chains are getting affected, that will be sickle cell trait. So that is in heterozygous condition where you have HbA, HbS. So as we know, here there is sickling can be observed, the RBC getting into sickle shape. So what is the molecular basis of this sickling? When there is a low oxygen tension, the HbS molecules will aggregate. They undergo aggregation and then polymerization. So when this deoxygenation is continuing, that means when a recurrent hypoxia is occurring, they get into a sickle shape. So this HbS molecules are aggregating and polymerization happens to get into the sickle shape. Now what if oxygen tension is returned back to its normal? It is reversible. But at the same time, if there is some kind of a recurrent stress, recurrent hypoxia or recurrent oxidative stress, in such conditions, sickling can be permanent. That means they can damage the red cell membrane and there will be irreversibly sickled cells. So what is the problem with these sickle cells? Yes, they can cause many problems. That means they can aggregate and they can block small blood vessels. So even sometimes they can slow down the blood flow. Also, these sickle cells have high level of adhesion. That means they have high level of expression of adhesion molecule. So they are sticky to the endothelium. And even if they reach into the splenic circulation, there they can undergo extravascular hemolysis. So since there is hemolysis, there will be clinical features of anemia and jaundice. So in sickle cell anemia, four types of crisis can happen, in which the first one is sickle cell crisis. So this is also called as vaso-occlusive crisis. That means the problems that can happen when the sickle cells are blocking the small blood vessels. So that can even disrupt the blood supply to various tissues. So it is an infarctive crisis and therefore it is painful. So the microcirculation is blocked by the sickled red cells, thereby there can cause hypoxic injury to the tissues, and that's why it is called as infarctive crisis. Some examples are given here, that is in case of the bone, they can even cause inflammation like dactylitis and hand-foot syndrome. In lung, they can cause acute chest syndrome. In the spleen, when there is a recurrent splenic infarction, they can cause autosplenectomy. In case of sickle cell anemia, autosplenectomy can happen. That is due to the recurrent splenic infarction. So that is why for the patient recurrent infections can occur, because since there is autosplenectomy. Since the spleen is damaged, recurrent infections can happen to this patient. Now the another crisis that the patient can get is hemolytic crisis. So here actually in the initial stage, when the sickle cells reaches the spleen, actually initially there is a splenic enlargement, splenomegaly, but at the same time the recurrent infections to the spleen, that means the arterial supply to the spleen is also is getting hampered, that is actually causing to the autosplenectomy. So initially there is an enlargement of the spleen. In that condition, more extravascular hemolysis can happen. That means there will be a marked increase in the hemolysis. So that is hemolytic crisis. And aplastic crisis is actually related with parvovirus infection. Sequestration crisis usually occurs in children when there is a sudden trapping of blood inside the spleen or inside the liver. When there is a sudden trapping of blood, it can cause rapid enlargement of the organ so that there is a drop in the hematocrit, and that can even lead to hypovolemic shock. So this is actually usually seen in case of children, the sequestration crisis. So this is the vaso-occlusive crisis, which you can see in sickle cell anemia. So it can affect different body parts. Then the effects of vascular occlusion can be stroke, retinopathy or blindness, acute chest syndrome. It can even cause autosplenectomy, which can lead to several infections. Then renal infarcts can occur and papillary necrosis. Even bone necrosis can happen usually to the femur, the neck of femur, and osteomyelitis. Then some leg ulcers can happen. So usually they need blood supply to heal the ulcer at the same time. Here, since the blood supply is not very smooth, here this ulcers will not be healing. And even inflammation of the digits can happen, that is dactylitis. Now when you get this chronic hemolysis, as an effect of that, there can be congestive cardiac failure, jaundice, chronic hemolytic anemia, or pigment gallstones. So in the peripheral blood, the hemoglobin is decreased and the hematocrit is decreased. So the ESR is reduced in sickle cell anemia. Here you can get anisopoikilocytosis, and you can see sickle shaped cell, that is the most characteristic one in sickle cell anemia. At the same time, which we have already told that target cell can also be seen in sickle cell anemia, and even some other cells like ovulocytes. Polychromatophilia is observed in sickle cell anemia. Now, sickling test. Sickling test is actually when you add some reducing agent like 2% of sodium metabisulfate or sodium dithionite, when you're adding into the blood sample of the patient, it can induce sickling. So when you get a blood sample, you can add this reducing agent. So when you observe sickling, that means you can actually cannot differentiate whether it is sickle cell trait or sickle cell disease, but it can be any one of the two. So that is sickling test. So since we have told that in case of the sickling test, you cannot actually differentiate whether it is a sickle cell trait or whether it is a sickle cell disease. So you must have to differentiate between the two, and that is why you get hemoglobin electrophoresis. So when you do this hemoglobin electrophoresis, you can get two lines in case of the sickle cell anemia, because HBS is slow moving as compared to HbA. So you can see that in the patient of a sickle cell trait, you can see two lines in which the first line, the line which is below, it is HBS because it is slow moving, and HBA is fast moving towards the anode. At the same time, you can see in sickle cell anemia, the sickle cell disease, you get a very dark band because both are HBS band is so darkened, and you can see two lines are obtained in case of a sickle cell trait, whereas you get one line in sickle cell anemia. So when you compare it with that of a normal patient, you can get a single line, but still it is, since it is HBA, it is fast moving towards anode. So that is about hemoglobin electrophoresis, in which you can differentiate between sickle cell trait and sickle cell anemia. So just like as we have said in thalassemia, which we have used high performance liquid chromatography to confirm the diagnosis, likewise here also we can use high performance liquid chromatography to confirm the diagnosis. Now let us learn about immunohemolytic anemia. So we have already seen that it is an extracorpuscular defect. That means the defect is outside the red cells. Here it is immune mediated. The hemolysis is immune mediated. That means the destruction of RBC is mediated by some antibodies that is binding to the RBC. So here it can be autoimmune hemolytic anemia, or it can be alloimmune hemolytic anemia. That means the antibody can be produced against the antigen which is present in our own body, or sometimes the antigen can be foreign. It can be from other individual, a different individual. So in case of autoimmune hemolytic anemia, here it can be a warm antibody type, cold agglutinin type, or cold hemolysin type. In case of a warm antibody type, the antibodies involved are IgG, which are active at 37 degrees Celsius. So it can be primary or secondary. And in case of a cold agglutinin type, the antibodies involved are IgM, which are active at 4 degrees Celsius to 18 degrees Celsius. It can be acute or chronic. Now in case of a cold hemolysin type, here the antibodies involved are called as Donat-Landsteiner antibody. So this cold hemolysis is seen in patients with paroxysmal cold hemoglobinuria. So in the case of alloimmune hemolytic anemia, here the antibodies are produced against the foreign antigen. That means the antigen from a different individual. So that can be during mismatched blood transfusions, when the person is receiving blood from a different individual. In that case, the antibody can be produced against that RBC. So otherwise, another condition you get this is hemolytic disease of newborn, where the antibody can develop as a result of mixing of blood between the Rh negative mom and Rh positive fetus at the time of delivery. So that is hemolytic disease of newborn is another condition where you get alloimmune hemolytic anemia. So at last we are going to discuss about paroxysmal nocturnal hemoglobinuria. So this is an intracorpuscular defect. That means the defect is present within the RBC. So we have seen that most of the cases of intracorpuscular defect is acquired. At the same time, the inherited cause of intracorpuscular defect in hemolytic anemia, it is paroxysmal nocturnal hemoglobinuria. So here there is a mutation of a gene called as phosphatidylinositol glycan. As a result, there is deficiency in the synthesis of a protein, that is GPI linked protein. As a result, what is happening is that there is complement activation. So complement activation, and it leads to intravascular hemolysis. That means The RBCs are destroyed within the systemic circulation. So since they are destroyed within systemic circulation, the hemoglobin is released into the blood, and this can be filtered by the kidney, so there can occur hemoglobinuria. There is alteration in the color of urine. So the dark color of the urine is due to the presence of acid hematine. Also here you can observe thrombosis in hepatic, portal and cerebral veins. So now in the lab diagnosis you can do Ham's acidified serum test, sucrose hemolysis test, and another one is flow cytometry. So when you do this flow cytometry, you can detect that the RBC is deficient of this GPI linked proteins like CD55 and CD59. So this is very useful in the diagnosis of paroxysmal nocturnal hemoglobinuria. So that's all about the session, and hope you love the session. Thank you.